look at next is the electrical activity of the heart and how we record that, which is what the EKG is about. And to begin with, while I have this picture up, I want to point out what we're going to be looking at in a second, sort of to correspond with what you're just looking at in the models. The electrical activity, or what we call the cardiac conduction pathway, originates out of the, those are old and they fall apart. Okay. Originates out of the right atrium. So we're actually going to talk about two structures which aren't pointed out here, but the SA node, and you'll find out what that is in a second, is located in the sort of superior wall of the right ventricle, and the AV node is located in sort of the inferior wall. So I just want to point out where those are relative to what you're just looking at. And I'm doing that separately now because I'm going to switch to using this presentation software, which when I have it running is using the whole screen. But again, what we're talking about here is called the cardiac conduction system. It's the process that electrical signals or action potentials are propagated through the heart and therefore control the heartbeat. Now, when we talk about skeletal muscle contracts because the nervous system tells it to. A motor neuron synapsing at a neuromuscular junction releases acetylcholine and causes the skeletal muscle to contract. Cardiac muscle is different. It doesn't have to have any outside input telling it what to do. The cardiac conduction system starts with cells that are autorhythmic, which is to say that they generate their own action potentials at a regular pace. So the numbers are different from what you're used to seeing because what's going on in the membrane is a little bit different, but the idea is still sort of there. We have an action potential. We have a rapidly depolarizing rising phase that goes up to a peak, and then it turns around and repolarizes going below threshold and heading towards the resting membrane potential. What's different here is that they never sit at a resting membrane potential. There's always something changing in the cell membrane. And what happens after they've repolarized, they then turn around and start depolarizing slowly again up to threshold. And then when it hits threshold, it's going to rapidly depolarize to its peak, and then rapidly depolarize to its peak, and then repolarize again, and then it'll come back up. This segment in here, where it's slowly going back up to threshold, what's labeled as the pre-potential here, is spontaneous depolarization in the sense that the cell doesn't sit at resting potential. It just slowly, on its own, depolarizes. The reason this happens is that these cells have a set of sodium channels that are always open. So there's always sodium entering these cells kind of slowly. And once the membrane potential reaches threshold, which in this picture is depicted as negative 40 millivolts, once it hits that point, then all of the voltage-gated sodium channels will open up and you get an action potential just like you studied back in ANP1. Okay. These are autorhythmic cells. They do all of this on their own, and they're always spontaneously depolarizing in between action potentials leading up to the next one. The amount of time it takes for it to spontaneously depolarize, which in this is, we go from the beginning of one action potential to the beginning of the next action potential over 0.8 of a second. If we wanted the heart beat faster, then the spontaneous depolarization would occur quicker. And if we wanted it slower, the spontaneous depolarization would last longer. Okay? Just spacing out or shortening up the gaps between the action potentials. The 0.8 of a second here corresponds to your average resting heart rate of about 72 to 75 beats per minute. The heart actually will beat on its own without any input. Resting membrane potential is the heart modulated down to a slower heart rate by itself without any parasympathetic input or sympathetic input either. The heart's going to beat normally at about 100 beats per minute. Okay? And so that means that the action potentials will be coming quicker. I don't know the exact interval, but say it might be a 0.6 of a second or something like that gap between action potentials, whatever it might be. The cells that are doing this, these autoarrhythmic cells, what we call the pacemaker cells, are located in a few different places, but the main location of them is what I mentioned a little bit ago as the SA node. SA stands for sinoatrial. This is in the right atrium. Now, the right atrium is also kind of referred to as a sinus. When we're talking about circulation, a sinus is usually an enlargement of a vein. And the vena cava is a vein. Really, where the inferior and the superior vena cava come together, the right atrium is pretty much just an enlargement of that vein. There's no valve between veins and atria. So it's just the vena cava is a little bit larger there. It's like a sinus. And that's why it's called the sinoatrial node, because it's here in the wall of the right atrium. There's also the atrioventricular node, or the AV node, which is also in the right atrium, but it's at the border between the atrium and the ventricle. So it's called the atrioventricular node. These cells are also autorhythmic, but they have a slower pre-potential. They will not depolarize as quickly as the SA nodes will. And so if the SA node's doing its job, it's actually going to set the pace for the whole heart and override the pre-potential of the AV node cells. In the picture here, they depict these three connections from the SA node to the AV node. There are, in fact, some specialized cells that connect between them, but it's really not that important. And in some depictions, you won't even see anything connecting the SA node and the AV node, because through those intercalated discs, the cells are connected. And from the SA node, all of the cells of the atrial wall, both on the right and the left side, all of them are connected together. When the SA node depolarizes, it sends depolarization spreading throughout all of the cells of the right and left atria. The AV node is in the wall of one of those atria, specifically the right atrium. So it's going to get depolarization spreading to it, whether we consider these three little lines here or not. So like I said, in some sources, they don't even put these internodal pathways in. They're kind of implied. But leaving the AV node, the rest of the conduction pathway is very explicitly laid out because it's very important where it is. Leaving the AV node, there's a bundle of fibers called the AV bundle. Again, AV for atrioventricular. The AV bundle branches into right and left halves, which we call the bundle branches, the right bundle branch and the left bundle branch. They run in parallel through the wall down the middle of the ventricle, called the ventricular septum. And the right bundle branch then goes up into the right ventricular wall, and the left bundle branch goes into the left ventricular wall. Branching off of the bundle branches are more fibers called Purkinje fibers. They're named after a dead white guy, Purkinje, but there's not a better word for them. And also, I kind of think the name Purkinje sounds kind of cool, so I like saying it. But actually, that's not the way that you pronounce his name. It's Purkinje or something like that. But he was a very prolific anatomist, so there are a lot of things in anatomy named after him. And these are one of them. I've seen some sources call those conducting fibers, which is not a great name for them because everything in the conduction pathway here are conducting fibers. These are really the ones that go from the conduction system and connect to the muscle fibers of the ventricle. There are some branches going to those papillary muscles that I pointed out earlier that control the tendinous cords on the AV valves, and then also just generally going to the rest of the ventricle. In pictures like this, which is always depicted in 2 dimensions, it makes it look like the bundle branches just go up either side opposite from each other. But in fact, they kind of go all the way through all of the ventricular wall in 3 dimensions. And it's never depicted very well in a picture like this. There was a picture that I found a while back. I made it the wallpaper on my phone for a while, but I can't remember where the original source was. But somebody had taken, I can't remember now if it was an X-ray image with something labeling those fibers or whatever, but it was a real 3-dimensional image of what those the conduction pathway looks like going through the ventricles. A really cool picture, but I have lost the source and I can't find it very easily anymore. And it's not the wallpaper on my phone anymore either. But these pictures are a little bit misleading. It looks like there's just this one bundle branch going up one side and one bundle branch going up the other side, but really they kind of radiate through all of the left and right ventricular walls. The point of the pathway here is to coordinate the conduction and therefore the contraction of the muscles in the heart. These are cardiac muscle cells. They're just specialized cardiac muscle cells. They're specialized for conduction rather than contraction. They don't really generate any force that's going to pump blood. Rather, they direct all of the other muscle cells to contract, and those are the ones that are going to be responsible for that. Now, the pathway follows a very predictable series of events. So I started getting something I'll talk about in a second, but this just names the different pieces that we saw top. But under conduction pathway, this is what happens. Those autorhythmic cells in the SA node start depolarization, begin the excitation. That spreads through the atrial walls on both sides, which is going to include the internodal paths that connect to the AV node. The AV node will then spread that conduction along into the AV bundle, which then branches right and left, going in parallel in the interventricular septum, and then they turn up into the ventricular walls on either side. And the Purkinje cells connect from the bundle branches out to the muscle, the rest of the muscle in the ventricles, what's called the myocardium. So this is just the pathway described in the series of events that lead to it. I started to talk about the SA node and the AV node both being autorhythmic, but they're not autorhythmic at the same rate. The SA node will fire at a rate of 100 beats per minute left to its own devices. That's faster than resting heart rate, because normally what happens is your parasympathetic system slows that down to the 72, 75 beats per minute range. The AV node also has an intrinsic firing rate, which is about 40 to 50 beats per minute. When the SA node's doing its job, it's going to set the pace for the whole heart and override that 40 to 50 beats per minute with whatever rate it's firing at. But the AV node's there with its own intrinsic rate in case the SA node fails. If your SA node's not working and it's not setting the pace for your heart doesn't just stop beating. You have this backup plan where the AV node can fire a little bit too. It's a slower rate, one, so that it can be overwhelmed by the SA node for normal beating. And it's not like the two are trying to compete for your heart rate. And also, it's at a rate that's enough for your cardiovascular system to maintain its basic function, which is mostly to get oxygen to your brain. You're going to need oxygen in a number of other tissues, but when your heart's beating at 40 to 50 beats per minute, you're not going to really be able to sustain a whole lot of skeletal muscle contraction. You'll get tired very quickly. But it's more important to get the blood to your brain so that the brain's getting all it needs. If the AV node fails also, the ventricular fibers, the AV bundle, the bundle branches and those sorts of things, also have an intrinsic firing rate of about 20 beats per minute. Now, that's the bare minimum to get blood to your brain so that you don't die, and blood to important muscles like the diaphragm. There are probably people walking around today, or I wouldn't say walking around, but riding their scooters around today at least, who are working on AV node autorhythmic cells. Their SA nodes aren't working, and they're getting by with 40 to 50 beats per minute. And they're like, there's nothing wrong with me. I don't need to see the doctor or whatever. And they get on their scooter and they ride around. I say scooter because if they're walking around, they're going to get tired very quickly. And they figure they're just out of shape and whatever. But really, there's probably something wrong with their heart. There's nobody out there that's relying just on their ventricular fibers. Really, the ventricular fibers don't do enough even to deal with the force of gravity on blood trying to get up to your brain. You have to be basically laying down, and hopefully in the back of an ambulance or in a hospital at the time, if the ventricular fibers are there. That's sort of the last-ditch effort to make sure that you don't completely lose cardiovascular function. With modern medicine, we have interventions that we can deal with that, but it's present because over the course of all of human history and prehistory, there might have been situations where that allowed people to survive just a little bit longer and they were able to recover on their own or something like that. But generally, it's kind of a last-ditch effort, and if you're at that point, not a whole lot's going to happen. If you're in the midst of a heart attack and the AV node and SA node are damaged by that because you're scared by some predator that's chasing you down, and you fall down and you can't run anymore, and your heart's beating a little bit to try to keep you alive, of course, you're not going to survive the predator. But there might be some situations where that might help. And I'm just trying to paint this sort of prehistoric human story there. But under normal circumstances, everything should be controlled by the SA node, and that 100 beats per minute is its intrinsic rate, which is usually slowed down by the parasympathetic system there. Now, there's a series of pictures I want to run through that just paint the picture of what's happening following through what the conduction system is doing. At the beginning of a heartbeat, the SA node starts by depolarizing. So that's colored purple to represent that depolarization. And that's time 0. That's the instant we start a heartbeat. And then over the next 50 milliseconds or so, that depolarization is going to spread from the SA node through the walls of the atria. And by about 100 or 150 milliseconds, that depolarization spread through all of the atrial walls, and the atrial walls will start to contract. There's about 100 millisecond delay so that the signal doesn't move out from the AV node just yet, allowing the atria to contract. And then once the atria contract, the signal is going to travel from the AV node, which actually it started in the previous picture, along the AV bundle into the bundle branches, down through the interventricular septum towards the tip of the heart, which is called the apex. And there's a timestamp for that. Once it gets down to the apex, it'll go up through the rest of the bundle branches and through the Purkinje fibers, and the depolarization will spread throughout the ventricular walls and cause contraction of the ventricles, which I think is the last picture. Yeah. So the conduction pathway is basically laid out for the depolarization to follow that series of events. What it means is the atria contract first and then the ventricles contract. That's the way that the heartbeat works. And I didn't quite depict that correctly. The atria contract and they're relaxing and the ventricles contract. So it's sort of beat, 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 beat. That's the heartbeat. Okay. And in lecture, we'll talk a little bit more about what's going on there. And the heart sounds actually do follow that kind of rhythm that I was just describing. But these pictures are kind of laying that out. We can measure this electrical activity using an EKG, and that's kind of the last thing we want to cover here, which hopefully a half hour will be plenty for. Now, I want to say a few things about what this thing's called. Here, in what I'm showing you, they abbreviate this ECG, and I think the book uses that also, ECG down here. I prefer EKG for a couple of reasons. One, that's its more appropriate abbreviation. The EKG was originally just invented by a Dutch guy. I think it was Dutch. And back then, most physiology was handled by people in the Germanic countries. So the de facto language of science for physiology was German. So electrocardiogram, spelled cardio with a K, because that's the Germanic spelling of it. ECG is just taking electrocardiogram that's now been sort of changed into the English spelling, and therefore the K becomes a C. So that's what it's referring to. Another reason I prefer EKG over ECG is because it's harder to confuse that abbreviation with other abbreviations. So this is the electrocardiogram. There's something called an electroencephalogram, which is the EEG. And EEG and ECG sound much more alike than EEG and EKG. So having that K, it's very obvious that you're talking about the electrocardiogram there, even though it's a little antiquated as far as what that stands for. So I will always refer to it as the EKG, even though in the reading you'll probably see ECG or something like that. In print, it's easy to tell that that's referring to the electrocardiogram. It's just verbally, the K is a little bit more obvious depiction of that. Now, this is showing you, well, up at the top, sorry. Come on, go away. There, up at the top, we're seeing a series of heartbeats that have been recorded with EKG. And then they're sort of outlining two in the middle, which we're seeing a little bit more detail down below. Basically what's happening here, what we're looking at is a piece of paper that's being drawn on by a pen, and the pen moves up and down depending on electrical changes that we're recording from the heart. And so each of the times that we see a bump in one direction or the other, that's the pen moving because of an electrical change that's being recorded. The EKG trace starts with what we call the P wave, and then it's followed by the Q and the R and the S wave, which are collectively referred to as the QRS interval. They come so quickly together, we don't talk about them individually. We just QRS is sort of one big event together. And then following that is the T wave. So it goes P, Q, R, S, T. And then the next one's going to be P, Q, R, S, T. And then the next one's going to be P, Q, R, S, T. There's a reason why the P wave is called the P wave, and then it just goes in alphabetical order from there. But I don't actually remember the story of what it's called, but that's the P wave. The P wave represents the electrical change in the heart that is the atria depolarizing. So the SA node depolarizes, which begins the P wave, and as that depolarization spreads throughout the atria, it gets up to its peak. And then the depolarization ends. The cells are still electrically active, but we don't really see a major change in the electrical activity. So it hits a peak, and then the pen goes back down to the zero, and we have kind of this little flat line part right there because there's no change in the electricity to mention. Atria stay depolarized for about 100 milliseconds. And so we don't see any change, so the line's back down here at zero. And then at about 100 milliseconds, the atria repolarize and the ventricles depolarize. Those two events are kind of overlapping, and we see them all together within the QRS complex. Really, the QRS complex is just what's happening in the ventricles. What's happening in the atria is, electrically speaking, very small, and so it gets hidden by everything else. Again, after the depolarization starts, the pen goes back to the flat line 0 area for a while because there's no change in the electrical activity. The cells are depolarized at this point. They just maintain that depolarization. And I said it's about 100 milliseconds in the atria. It's about 250 to 300 milliseconds in the ventricles. And so at the end of that, once they repolarize, we see the T wave. Okay. So from the QRS complex or interval, not interval, yeah, complex, QRS complex, those three together, through the T wave, what's the Q to T interval down the bottom, that's basically how long the ventricle walls are depolarized, and therefore they're going to contract. Okay. The PR interval is sort of the same thing for the atria. I don't care too much about these things that are labeled intervals, the time points there, or the segments, more just what the different events mean. P is atrial depolarization, QRS is ventricular depolarization, and T is the ventricular repolarization. We don't have a specific thing that's the atrial repolarization because it's overshadowed by the very big QRS complex. And then it all starts over again in the next one. The peak from one QRS complex to the next QRS complex is basically the interval from one heartbeat to the next. That's the easiest thing to see on EKG. And this is all on a graph paper. And if you're familiar with reading EKGs, you can actually count how many boxes there are from one to the next and establish what the actual heart rate is. This graph paper isn't drawn with the major lines where you can actually see. So there's, for every 5 boxes across, there's a dark line separating out. So we have major and minor things, and those lay out the time course a little bit better. And people can, who are used to looking at these, can look at this immediately and tell you what heart rate this represents. And this should represent about a 75 beats per minute heart rate. Again, because it's 0.8 of a second. Whoops, you can't see that. Up at the top here, you can't quite see it up in the black strip there. It says 800 milliseconds, which is 0.8 of a second. And again, that's the time that a heart rate would, the time between heartbeats, which represents a heart rate of about 75 beats per minute. Come on. All right, Prezi's been freezing up on me a little bit. Okay. The other stuff in here I'm going to talk about in class, which has to do with what's going on at the cell membrane and action potentials and that sort of thing. What I want to get to now is I have a link here to the Nobel Prize electrocardiogram website, kind of like the blood typing stuff we did last time, but for this instead. And apparently the code doesn't quite work here. But so there's an EKG, and of course they call it ECG, which is kind of funny because this is in a more Germanic area, but they're using that English redefinition of it or so. So there's a link down here to a article, just like we saw with the blood typing. And I might not have the Flash player updated on this, which will be kind of unfortunate. I'm going to switch over to, oh, I can't do that. Okay, we'll see what happens. I just want to touch on a few things here. This article kind of covers a lot of the stuff I just did. Oh, I know what. Shoot. Great. They've updated things and are now using a version of Flash Player that we apparently haven't updated this computer for. let me see if switching to Firefox will help. No. Okay. Well, Firefox doesn't help at all. So this kind of goes through a lot of the stuff before, and hopefully I'll be able to show you what's supposed to be here in a second. So it talks about the cells are autorhythmic. They generate their own electrical signals. The thing about the EKG is that this guy got the prize because he was able to figure out a way to non-invasively record reliably the electrical activity of the heart. And all of this is happening at the skin in the range of about 1 millivolt change. But it's a very sensitive technique, and we can get very reliable information from it. Oh, that's interesting. They took that out. Oh, no, they didn't. It's down here. The electrodes that we record from the skin are placed, in these kind of positions. This picture down here depicts an important aspect of how they're arranged. There are 10 electrodes, and here we're only looking at 3. There's one on the right arm, one on the left arm, one on the left leg. Those 3 locations kind of define a triangle, which is referred to as Einthoven's triangle. And what's happening in the EKG is 2 or more electrodes are compared, and we're looking at the changes in electrical activity across the dimension defined by those. So we can compare the right arm to the left arm, which is what we call standard lead number 1. We can compare the right arm to the left leg, which is standard lead number 2, or we can compare the left arm to left leg, which is standard lead number 3. And I didn't get the positive negative comparisons there. I just said the basic locations. So you can imagine this is the top of a triangle, and these are the 2 sides of the triangle. It'd be kind of nice if this was drawn actually represented over the heart, because standard lead 2 is parallel with the axis of the heart. If we drew a line from the top to the bottom of the heart right through the middle, it would be parallel with standard lead number 2. And so when we talk about the EKG trace, which I showed you a little bit ago, that's the recording we would see comparing the right arm and left leg electrodes, the standard lead number 2. All of those events, the P wave, the QRS complex, the T wave, occur no matter how we look at it. They just look different with all the different comparisons. So there are the 3 standard leads we see here. If we compare all 3 of those locations together in different combinations, we get these 3 leads, which have different names. They're called augmented leads. And then not depicted in this picture, there are 6 electrodes that go across the chest, and each one of those compared to a grounding electrode, which is on the right leg, gives us a picture of what's happening at that spot on the relative to that spot on the chest. And those are called precordial leads or chest leads, giving us a total of 12 leads. 10 electrodes, 12 leads, based on how we compare those together. And I'm just mentioning that because we're going to see something a little bit where we'll see those 12 different leads. So here where they're talking about mountains and valleys, this is just laying out the P wave, QRS complex, T wave, which we just talked about. The nice thing about an EKG is we can use it to see what's happening physiologically in the heart, the electrical conduction, and it'll tell us when there's a problem, what kind of problem it is. So we're going to see, hopefully in a little bit, cartoons like this heart, and we'll see the conduction pathway occurring. There's a big black patch in the left ventricle wall here that's dead tissue, which is the result of a heart attack or cardiac infarction, which interrupts the way that the electrical activity is conducted around the heart. And we'd see that in the EKG. There's also a little black patch on this other heart cartoon here. This is similarly dead tissue, but not necessarily from a heart attack. This is specifically the cells in the left bundle branch that are dead. So the conduction pathway ends abruptly right there on the left side. And because the signal's not sent through the left ventricle the way it's supposed to be, the EKG will look different. And so we can use the EKG to see these kinds of things. The rest of what it goes on here is just talking about action potentials and that sort of thing. It ends with mentioning pacemakers, which are ways to correct some of these cardiac conduction pathways. There's a game for this too, and let's hope it works. It's not a flash player. Yay, it worked. Okay. So the thing that I couldn't get because it said we had the wrong flash player thing, we're going to see that in something like that in a second. So in this game, you have 4 patients to see. They're just named by different colors. Mr. Yellow, if we call him in using our intercom button there, he shows up. We know he's Mr. Yellow because he has a yellow tie. Gives us some information about him, and he asks, or he says that he's been sent here to get an EKG done. Is it going to hurt? And in your best bedside manner, you say, no, it's not going to hurt. Take off all your clothes and go lay down. And so he does that. Now, before I click this button, I just want to be sure that nobody's going to be offended by what they see. The Nobel Prize is administered by a Scandinavian country. I think it's Sweden. Yes, it is supposed to be Sweden, but there are some of the prizes that are actually administered out of Norway, I think, and I can't remember which ones are which. But anyways, Scandinavian nonetheless. And so their sensibilities are a little different than what we have here in America. So he's wearing yellow Speedos. So, but he's Mr. Yellow, so they're yellow. Now, here we have those 10 electrodes that need to be placed on the body. They're labeled, and if you hold the mouse over it, it tells you where it goes. So this is the left arm electrode. This is the left ankle electrode, the right arm electrode. And then we have one here that's the right ankle electrode. It's not one of those 3 that make up the triangle. Rather, it's a non-recording electrode, or more appropriately, a ground electrode, so that it subtracts out all of the background electrical activity so we can really see what's going on. And then the other 6 here are the chest electrodes. Excuse me. Number 1 is placed just right of the sternum, and then 2 through 6 go across all the way to the lateral side. You do not have to place them exactly where they're supposed to go. Just drag them over the chest, and they'll get placed where they're supposed to go just fine. And it looks like I'm hitting them all right, but you don't have to be very exact. And so they're all there. The second patient that you have, you won't have to do that. It'll have a little extra button, I think, down in this corner. You just hit that and it automatically puts all electrodes. But the first patient you deal with, you do it so that you can see how they're arranged. And then you go to the recording. Now, this is all going by really fast because it's in real time, and I'm going to switch to the schematic in a second. But what we have over here is a thing that we couldn't see a second ago. Actually, not the exact thing. It was a normal heart. But this one, he has a problem. But we see the SA node, the AV bundle, and the bundle branches going down to the apex, and then the right and left side. The Purkinje fibers themselves aren't really depicted here, but that's just because they try to simplify the picture a little bit. The yellow represents conduction, and then the wall of the heart will darken briefly when it depolarizes, leading to contraction. That's what we see here. And everything's going by very quickly here. If you want to, you can pay attention a little bit. These are standard leads 1, 2, and 3. We can switch to the augmented leads, or we can switch to each of the chest electrode-based leads individually. But we've only really talked about what's going on in standard lead number 2. There are P, Q, R, S, and T waves in all of these. They just look different depending on which one we're looking at. It's easiest to make sense of this by switching to the schematic view, where it's not going by in real time. Now we have arrows, we can step through the process. So everything begins with the SA node firing up, and that depolarizes the atrial walls, including the internodal pathways that connect to the AV node. That's when we see the P wave. Okay. And then the signal will continue along from the AV node to the AV bundle. We won't see anything in the EKG because that electrical activity, the few cells involved in what's lit up there, isn't enough to see anything in the EKG. And besides, the atrial walls are completely depolarized at this point. And then we step along and we start into the QRS complex when the conduction pathway starts to go down the, what is that, the septum. Now this guy has a little black spot right there in the left bundle branch. And so it doesn't quite do what we'd expect, and it doesn't quite look like we'd expect the QRS complex to look like at the beginning. And that's supposed to happen. And then it goes down to the apex on the right side and out to the end. And then eventually the left side gets darker, representing it depolarizing. Now, the left bundle branch is not conducting, so the signal's not going directly to the left side. The left side lights up at this point, at the same time that the right side's reached the end of its conduction pathway, because there are connections all the way across the ventricles. And so even though the left bundle branch isn't working, the left side of the heart gets its information. It's just it's getting it a little late, and it's not getting it in the correct order from the apex up to the top. But we hit the peak, and that's when things are completely depolarized everywhere in the ventricles. The QRS complex has this little funny shape at the end because of what's happening on the left side. And that's what we would see in an EKG, telling us that there's a problem with one of the ventricles. And then nothing's going to happen in the animation because there's nothing that animates the repolarization. But we hit the last arrow and it just plays out through the T wave and it's done. Okay, so that's our guy's EKG trace. Doesn't look like we'd expect. The QRS complex is a little weird. It's very wide at the bottom, and there's obviously problems with it. But we can see in the animation that he obviously has problems with his left bundle branch. Okay. You can step back and forth through these things if you want to watch what's happening in a little more detail. But when you're done looking at them, the arrow here takes you back to your office. You can look at the EKG that was captured from that patient and compare it to reference ones. Now there are 4 bookmarks, one that's blockage, one that's arrhythmia, one that's normal, and one that's after a heart attack, cardiac infarction. We have 4 patients, so we're basically trying to match the patients up with the conditions. So you look at the references, there's 2 pages here, so you're going to look at both of them. Page 1, we can look at that, and we just compare it to this. This doesn't look anything like our guy, but we can go to page 2, and now this looks a lot like our guy. The way that you can tell that is look at our guy's standard lead number 2 and look at the reference standard lead number 2. And they look very similar, especially that QRS complex that's very wide at the bottom. Also, just qualitatively look at everything, especially for these, the bottom 6 leads all look very similar. Not quite as big, one versus the other, but they all kind of do the same thing. Okay. But we actually know what's going on with this guy because we saw the animation. It showed us there's a blockage in the left bundle branch. Okay. You could certainly go through all of the other bookmarks and compare all of those, but we know the guy has a blockage because we saw it in the animation. So then you go to select the condition, and the only one that says blockage is the bundle branch block. Our guy, in fact, has a left bundle branch block, but this isn't making that point here. Check that, hit OK, and when you hit the arrow button to go on to the next patient, you have a choice of calling another patient or quitting the game and seeing your results. You'll see the patient's names that you've done and the diagnosis that you've given them, and then a green check mark if you've given them a correct diagnosis, and a red X if you've given them the wrong diagnosis. If you would like to, you can print out your results. Do not bother printing them out and giving them to me. That's not what I'm looking for. But you're going to complete this game, and there's going to be a question in the lab quiz about the results of this game, just like there was a question in the blood lab quiz about the results from the blood lab game. So complete this game and you'll be ready for that quiz. If you'd like to go back and read the article in a little bit more depth, you're welcome to, but I kind of went through that stuff here. In the for the blood lab stuff, I gave you a link directly to the game. Here, I'm giving you a link to the article itself, and just find the link to get to the game. I forgot to erase this link here, so let me just get rid of it now. I used to have a handout with examples of EKG traces, but I no longer need to use that because the book has that for us now, and that's not what I want. So pay attention in the book, and this is going to be relevant to the quiz a little bit. In the section that is electrical activity, I think down at the bottom it should have, after it talks about all this stuff, there we go, EKG and abnormalities, and it has some examples of some of them. And there's questions in the quiz that relate to some of what this is talking about. Normally I'd have time to talk about all of this, but running a little short on time today. So you can get it out of this. I used to have to explain it in lab because the books that we used before didn't have that, but this book does a good job of talking about these things, so it's all right there. Again, tomorrow we're going to finish the blood stuff in lecture. I'll start talking about the heart if we have time. Otherwise, we're going to get to the heart lecture stuff next week, and that'll kind of fit in with what's going on here. So, and also remember, next week on the 25th, we do not have lab because school's following a Monday schedule that day to make up for a snow day. But other than that, if you don't have any questions, that's it for today, and I'll see you tomorrow in lecture.